Okay. So what had we talked about before? We were talking about breast carcinoma, and we were doing the surgery part in that. And we had finished wide local excision or lumpectomy or breast conservation surgery. So what is it in two lines? It's nothing but you will just conserve the major part of breast tissue and just remove the lump and give irradiation to it. That's it. That's what wide local excision or lumpectomy is. And now we'll go to the other kinds of surgery. So it is such that in breast surgery, you have to do either breast conservation surgery or mastectomy. Okay, I'll write the classification. Surgery. There is breast conservation surgery, and then there is mastectomy, which is like you have to remove the entire breast or something like that. In that there is radical mastectomy.
Nitija, 1 second.
Ah. Okay, I'll start. In breast surgery, there are two major things you can do. One is breast conservation surgery or mastectomy. Mastectomy is not conservative. Like you get to you will have to remove the entire breast or probably even the surrounding structures. So there are 4 types in this: radical mastectomy, modified radical mastectomy, and simple mastectomy, and skin and nipple sparing mastectomy. So we are going to do radical mastectomy. Like try to, imagine the word radical. Like everything is removed in this. Okay. So what is radical mastectomy? What are the structures which are removed in this? So I just said everything from the breast to the surrounding tissues are removed. So you remove the breast and also the nipple and areola. Why I have mentioned this is sometimes there is something called nipple and areola sparing mastectomy. But in this case, they have removed this as well, and the skin is also removed, and fat, fascia, and lymphatics is also removed. Lymphatics is in the entire thing, even the axillary lymph nodes and everything, and the fat, the lymph nodes within the fat is also removed, and the fascia, pectoral fascia is also removed. So, okay. Axillary block dissection includes complete clearance of axillary fat and up to level 3 nodes clearance. Okay, I'll show you a diagram for this. Level 1 is here. Okay, this is the pectoral, this is the pectoralis minor, and here is the axillary vein. This is lateral to, level 1 is lateral to pectoralis minor. So this is level 1, level 2 and level 3. Sometimes it's only, sometimes only certain levels are removed, but in this case all of them will be removed. Okay. So even the axillary fat is removed, and level 3 lymph nodes, up to level 3 lymph nodes will be removed as well. And don't remember the entire thing in this, just remember the pectoralis major and minor will be removed. Just so that you can get an orientation, I'll show you how or where those muscles are and how they could be. See, this is right over the breast. First there will be a pectoralis major, and then pectoralis minor, and the third will be the fascia. So all of them in a layer will be removed. First the pectoralis major is removed, and then the pectoralis minor. This is the pectoralis minor which is removed, and then the fascia here will be removed. So as you can see in the diagram, this is pectoralis major, which will cover like this, and then the pectoralis minor, which is here, which will cover like this, and beneath this, below pectoralis minor is the fascia, which will also be removed. So yeah, just write all the structures in and around breast and you'll have your answer. And but importantly, what will you preserve? Axillary vein, it should be preserved. So where is the axillary vein? So see, cephalic vein will join with the will join with the basilic vein to form the axillary vein, which is somewhere around, like the breast is here and this is somewhere around here. This should be preserved so that the arm movements can be preserved. And Bell's nerve. See, if you injure this nerve, you'll have something called winging of scapula. I'll show you where Bell's nerve is. Okay. This is Bell's nerve or the long thoracic nerve. And this is the serratus anterior muscle, which is responsible for fixing the scapula. So if which is responsible for fixing the scapula. So if this is injured, then the serratus anterior muscle is injured as well. So then the scapula won't be fixed. So there will be winging of scapula. And cephalic vein. Yeah, obviously. You'll save the axillary vein, you'll save the cephalic vein, and then you'll also save the long thoracic nerve, which I just showed. And what are the disadvantages? It's pretty depressing for a woman to have her breast removed. So it's a mutilating surgery. You're removing the entire breast and poor cosmetic results. And lymphedema of the arm. Why is there lymphedema? As you're removing the lymph nodes, where will the lymphatics from the arm and breast drain into? Like there's no conduit at all. There's no pathway at all. So the just lymph starts accumulating and there will be lymphedema of arm. And then there is high morbidity rate. Yeah, because you're removing so much. The pectoralis muscles are like major and minor is also removed. The arm movements will be compromised. So yeah, it's not really a very great surgery. So now that we are done with radical mastectomy, we will go to modified radical mastectomy. Okay. I'm sorry about this, guys. Okay. So what is the difference between radical mastectomy and modified radical is with regard to pectoralis major. Pectoralis major muscle is compulsorily removed in radical. But pectoralis minor muscle may or may not be removed in modified radical. Okay, hope you understood. Okay, I'm sorry. Pectoralis minor may or may not be removed in modified radical, but pectoralis major and minor both are removed in radical. So this is the difference. So yeah, just write everything you know, like best, nipple areola complex, and then pectoralis fascia is also removed, but don't write the muscles. And then level 1, 2, 3 axillary lymph nodes. I just showed you the picture, right? 1, 2, 3 of the lymph nodes, axillary lymph nodes, and plus or minus pectoralis minor. Okay. In that there is a classification. Like it could be Auchincloss or Scanlon or Patey. In Auchincloss, the pectoralis minor is just retracted. I mean, this classification is based on how the pectoralis minor muscle is manipulated. In Auchincloss, it is retracted, but in these both, it is cut. So there is a entire separate heading regarding Patey surgery. It is nothing but modified radical mastectomy only, but the pectoralis minor muscle is cut. In simple mastectomy, it is like just remove the breast, NAC and fascia, same as this only. But but the muscles won't be touched. The muscles aren't touched. The pectoralis major and minor aren't touched. Importantly, lymph nodes are not removed. But in this case, all the level 1, 2, 3 are also removed. See how progression of a surgery is. In radical, both the muscles will be removed, okay? And then in modified radical, minor may or may not be removed. But in simple, the lymph nodes are only not removed. So it is like this. Skin and nipple sparing mastectomy, it is in the name itself. Modified radical.
Shirja, your voice is not audible. From the lymph node, the last. Hello.
This is very simple, guys. Radical is just remove everything. Modified radical is just be careful with the muscles, pectoralis major, minor, and lymph nodes. Be careful. And in simple, you just don't remove any lymph nodes. That's it.
Shirja, file is not shared.
Okay.
Only screen is shared.
Okay. So we are done with all kinds of surgery now. We are done with breast conservation surgery and then mastectomy, all the types of mastectomy.
Shirja, your voice is again not audible.
Okay, so this just leaves us with just one more surgery, and that is quad surgery. So it is in the name itself. We do a quadrantectomy, like entire segment of the breast containing tumor is removed. I mean, just remove the segment of the breast containing containing the tumor. See, this is not really a good method because breast does not have actual segments like how the liver does anatomically. So this is not a really practical solution. Anyway, A stands for axillary clearance. Remove all the lymph nodes. RT is for radiation. So just remember the word quad. C is for QU is quadrantectomy, A is axillary clearance, and RT is radiotherapy. So advantages of a modified radical. PT is modified radical mastectomy over Halsted. Halsted is nothing. Okay, a radical mastectomy has another name and it is also known as Halsted radical mastectomy. So what is the advantage? What are the advantages of modified radical mastectomy over radical mastectomy? Obviously, it is, some parts of breast will be preserved, so it is cosmetically better. And since the muscles are not removed, since the pectoralis major and minor is still preserved, the function of shoulder is better. And it gives a useful arm. But in radical mastectomy, since both pectoralis major and minor is both removed, now the arm becomes dysfunctional. Okay, so we are done with the entire surgery part. And okay, we have to manage the axilla now. Now that the breast part is managed, we have to think about the axilla. So what do you do in axilla? In early breast cancer with no clinical apparent node, and if the disease is not multicentric, SLN can be considered. Otherwise, axillary dissection is recommended.
Again, your voice has become low.
Oh shit! I held on to the microphone. Okay. So they're just saying what you have to do, like when should you do sentinel lymph node biopsy and when should you directly go for a axillary dissection. Okay. If at all it is early breast cancer and there are no palpable lymph nodes, And if the disease in the breast is not multicentric, as in if it has not involved multiple quadrants, then go for just do sentinel lymph node biopsy, because you don't know if it has spread or not. But if at all the lymph nodes are palpable, and if this is a late disease, and if the breast has multiple tumors in different quadrants, then go for axillary dissection. And yeah, sentinel node biopsy, I've done this in detail. Please go refer the notes. So we'll directly move on to complications of modified radical mastectomy. Okay, this is an important next question. Let's do this. Seroma or lymph collection. What is a seroma? Seroma is nothing but accumulation of fluid beneath the flap. See, what happens is, did you watch the video I had sent? Hello.
Hello. Audible, you're audible.
What is seroma? Seroma is accumulation of fluid beneath the flap. I just explained to you what a flap is. Okay, and then as you have seen in the video, you have seen that drains will be instilled inside the flap, so that you can drain all the seroma from it. So when are the drains removed? It is an important question. It is only removed after the output is less than 40 cc for 2 consecutive days. Okay. Drainage occurs for about 5 to 10 days. Like, this is normal for 5 to 10 days. Okay. How will you treat the excessive seroma? Aspiration under aseptic conditions, and you have to do pressure dressing. Complication with how will you treat them, that is important. So this is about seroma. And then secondary infection. Obviously, infection manifests as redness, discharge, fever. And how will you treat them? Antibiotics. Flap necrosis. Okay, like just how I explained to you, and as you can see in the video, the true mastectomy requires elevation of both upper and lower flaps. It should be almost skin thin. Thus, it predisposes to flap necrosis. Flap necrosis is whenever when the flap is too thin and when there is no adequate blood supply, it leads to necrosis. The upper flap will be until the clavicle, and the lower flap will be until the inframammary fold. How will you treat flap necrosis? Debridement, like just how you treat any other necrosis. Antibiotics, suturing, and skin grafting. Hemorrhage. Hemorrhage is, when will you see hemorrhage? After the surgery. If at all there is an infection in axillary tissue, if there is just imagine that there's an infection in the axillary tissue and the blood vessels present in the axilla get eroded because of that infection, and bleeding can occur. This is how hemorrhage happens. Like, they might ask you how hemorrhage happens after MRM.
Nitija, can you once again explain flap necrosis? Like, what leads to necrosis?
Okay. See, like, the surgery requires the flap to be very, thin. It should be as thin as the skin. So this will lead to a lesser blood supply to the flap. So hence it will lead to necrosis. Is that okay?
Okay, done.
Okay. How will you treat hemorrhage? As you have noticed, after every complication, you should be aware of how you will treat that complication. How will you stop the hemorrhage? This usually stops with pressure, but you may require ligation of the arteries in the OT, not somewhere else. Just not bedside, but you have to go to the OT, and you have to ligate the bleeders and put pressure. And when do you see pain and numbness in the axilla? Don't see the explanation, just imagine pain and numbness has everything got to do with nerve. Has everything got to do with nerves. So what is the nerve which is involved? Intercostobrachial nerve. This is very important. This is a question. So let us see where this intercostobrachial nerve is. If at all you injure this part, this nerve, so there will be pain and numbness in the axilla. Here. Okay. How will you treat it? It will subside in a few days' time. You just have to give analgesics. Shoulder dysfunction. Like I said before, shoulder or the arms will not be functional if at all pectoral muscles are injured. That is why radical mastectomy is not preferred, because the arm will be reduced to no function at all. But if at all, even after you do modified radical, and if at all you injure the pectoral muscles or retract it or injure it or remove it, it will lead to shoulder dysfunction. How will you treat it? It just improves over a period of time. Or injury or thrombosis of axillary veins. You remember, right? Axillary veins come somewhere here. Do this by 5 or 6-0 Prolene sutures. 6-0, sorry. Prolene sutures. And winging scapula. Winging scapula, it looks something like this. What will you have injured? Bell's nerve or the long thoracic nerve. If you have injured, then it will lead to problematic supply to the serratus anterior muscle, which I am coloring. So hence, which is attached to the scapula and the rib. These muscles will stop working, hence it will lead to winging of scapula. Lymphedema of the arm. Like I have told, right, if you remove the axillary lymph nodes, there won't be any way for the lymphatics from the arm and the breast to drain. So there will be lymphedema of the arm. So let's just go through the heading. Seroma, secondary infection, flap necrosis, hemorrhage, pain and numbness in the axilla, shoulder dysfunction, injury, thrombosis of axillary veins, injury to axillary vein, winging scapula, lymphedema. This is MRM only. And last part, adjuvant treatment. So we are done with the major surgery part. So now we have to go to adjuvant treatment. Like there are two types. Radiotherapy and systemic therapy will involve chemotherapy and a hormonal therapy. But for today, we'll just do radiotherapy. So what is radiotherapy? When do you need it? Indications. Like I keep telling you repeatedly, breast conservation surgery compulsorily requires radiotherapy. It is a dictum. I told this in the previous class. And if there is a positive lymph node on sentinel lymph node biopsy, if you get a positive finding, and locally advanced breast cancer, this has got to do with the stage. I don't remember. I told this in the previous class. Yeah, it has got to do with the staging of the breast cancer, and if it is locally advanced breast cancer, and if at all the tumor is greater than 5 centimeters. What are the types? Conventional whole breast irradiation and accelerated partial breast irradiation. Conventional, it is very simple. The treatment part is more simple than the actual breast chapter. It's very simple. You just have to remember the heading, and the answer is in the heading itself. Do it for 25 days. 25 days, and just single sitting in a day. 1 fraction per day. Dosage 50 to 54 gyries given to chest wall, supraclavicular fossa, infraclavicular fossa, internal mammary lymph nodes, just entire breast. That's why the name, whole breast irradiation. So let's do this again. Chest wall, supraclavicular and infraclavicular fossa, and internal mammary lymph nodes, breast. Yeah, in and around breast. That's how it is. Accelerated partial breast irradiation. This is for 25 days, but this is for 5 days. 1 sitting, 2 sitting, 50 to 54, but 30 to 35. Partial breast, not the entire breast. And accelerated, because you're doing 2 sittings in just 5 days. 2 sittings in just 5 days. But this is 1 sitting in 25 days. So where do you give this? Tumor cavity and adjacent tissue and partial breast. Just remember, this is the entire breast and this is the partial breast. Okay. So what are the extra points in the textbook? They have said that radiotherapy should be in a dose of 50 grays in 25 fractions. But what sir has said is, yeah, the 50 grays part is correct. 25 fraction is what he means is 1 fraction per day, which will lead to 25, which will go on for 25 days, hence 25 fractions. So yeah, just remember these 3 lines. So that's enough. We have learned the indications. So this is also done. If 4 or more nodes are involved, then the field of radiation should include supraclavicular or internal mammary chains. We have said this here. When will you, the only extra point given in textbook is when will you involve these structures other than the entire breast, is when more or equal to 4 lymph nodes are tested positive. Then you'll irradiate supraclavicular, intraclavicular fossa and internal mammary lymph nodes. That's it, I guess. Yeah, boosts are like extra, pulses of radiotherapy. Lumpectomy andre breast conservation surgery. Boosts after breast conservation surgery. And boosts are nothing but extra, additional. How will you do it is by adding 10 to 16 grays. That's it. So these are just the extra points. The parts marked in yellow are just the extra points. Otherwise, read this for radiotherapy, the entire part. Now, the last topic for today is brachytherapy. Brachytherapy in breast cancer. This is the picture. As you can see, brachytherapy is nothing but radiation, but it will be extremely close to the tumor, so much so that it is inside the, it is inside the tumor cavity itself. See, it is inside the tumor cavity. Looks very painful. Use of radiation sources in and close to the tumor. Okay. Breast is one of the organs which can be treated with brachytherapy. What are the points? Antandra, electrodes are put directly into the tumor cavity. The radiation will go to the surrounding structures from the tumor bed itself. This is brachytherapy. This will be, the electrodes are, first point is electrodes are in the tumor cavity and the radiation will go to the adjacent structures from the tumor bed itself. So we'll do the systemic therapy like hormonal therapy and chemotherapy tomorrow, and we are done with breast. Thank you.